Chapter 7, Dental Anomalies. Our learning objectives for today, or for this chapter, are that the student will be able to define what a dental anomaly is. They'll be able to discuss what intrinsic factors and extrinsic factors are, to discuss the difference between hereditary and congenital factors, and to define the various anomalies listed in this chapter. So a dental anomaly is a deviation of the dental tissues, whether it be enamel, dentin, or cementum. Potential causes can be intrinsic, which means within the body. So those would include heredity, metabolic dysfunction, and mutation, like gene mutation, okay? And then potential causes that are extrinsic or outside the body could be physical trauma, say having a fever, or chemical trauma, which would be due to things such as medications, biologic agents, nutritional deficiencies, stress, habits, and the environment. So now we've just answered 3 of our objectives, right? Defining the anomaly, what an anomaly is, and that is just something that's noticeably different or that deviates from the ordinary or normal. Intrinsic means that it's originating within the body. Extrinsic means that it is its origin is from outside the body. Okay, so something that happens outside the body is then affecting the body. Hereditary or versus congenital. People often get these two confused. If a condition occurs because of the individual's genetic makeup, that's when it's considered a hereditary factor. Okay? Then we have congenital, and that's a condition that occurs at or before birth. So a genetical condition is sometimes the result of hereditary, and sometimes a hereditary condition does not become evident until years after birth. All right. If a condition exhibits some evidence of an inherited tendency, but such evidence is inconclusive, it is often referred to as a familial tendency. Okay? So sometimes people don't develop their teeth, some teeth, okay? And I know in my family, a lot of them are missing canines or cuspids. And so that's a familial tendency. That's not due to our genetic makeup, but it is a familial tendency. All right? So let's start getting into what some of these anomalies are. And anomalies, I think, are kind of fun to study because you see all these different things that can happen. All right, so the first one we're going to talk about is macrodontia. And if you remember, I talked about this, I believe, in the last video in chapter 6. Macrodontia is where the teeth are abnormally large. Okay, so you can see, let me grab my pen here. I'm going to grab the color green to go against the red here. But you can see that this tooth here is abnormally large. Okay, so they just have a localized macrodontia, but some people just have overly large teeth throughout. And then some people just develop, this is actually a permanent dentition on this slide here, so I'll label these 1, 2, 3, and 4. Whoops. Okay, so you can see how small these teeth are, and it really leaves a lot of space between the teeth. A lot of these patients will go in and get veneers put on to kind of fill those spaces, kind of have a full mouth reconstruction. So this is when the teeth are too small. So that's variation in size. Then we have variation in numbers, okay? And as you can see in this third one, this is hyper, meaning too much. So multiple or extra teeth. So supernumeraries, these are termed supernumerary teeth, okay? And a lot of these teeth, I've read up on this case because this goes around the internet a lot. A lot of them actually are very loosely adhered in the palate, and they were able to take multiple out at a time. Very small roots, not well-formed teeth, some of them. But this does, you know, it's extremely rare. And of course, I've only seen it on the internet because it is so rare. All right, and then we have anodontia. And when you see it start with A, think of no. So no teeth or partially missing teeth. So you can have complete anodontia, which is all of the teeth are missing, or you can have partial anodontia, and that's where some are missing. So I selected this fourth picture because the laterals next to the third molars these are the second most commonly missing teeth, are the maxillary lateral incisors. Okay. All right, and remember, the extra teeth are called supernumerary teeth, and when they occur at the midline, so say they're occurring right here, often you'll get like patients will get like an extra incisor here. Those are called mesodens, okay? And if they occur in the third molar area, I wish I could type this here. If it occurs in the third molar area, they're called distodens. So that makes sense, right? Mesial at the midline, disto the furthest back, so the third molars. And then sometimes people get extra premolars, all right? And those are called, or excuse me, not premolars, molars, and those are called paramolars. So para meaning right next to the molars, all right? So those are the three most common ones. The board likes you to know mesodens, distodens. I haven't heard anybody say that they ask about paramolars, but if you're looking at answers and they say what is a supernumerary tooth situated next to, you know, buccally or lingually next to a molar, think para, right? Like the parathyroid, it's right next to the thyroid. All right. Next, we're going to talk about anomalies in shape. And the first one we're going to talk about is the odontoma. And the odontoma is a tumorous anomaly, and it's of the calcified dental tissues. So calcified dental tissues include cementum, dentin, and enamel, right? So remember, the calcification is determined by how inorganic it is. Okay, so when we're talking about calcified dental tissues, they're going to appear more white on radiographs. So what we're looking at here are these two bulges. Oops. All right. You guys can see them. All right. So these two masses, I would consider these probably the compound of the compound variety. So we have complex, and that's just a single mass of dentin, cementum, and enamel, and it's more like a large blob, and it doesn't have a specific shape. So all of a sudden you'll see what appears as kind of ground up enamel. Okay. Then we have compound, and that is multiple, right? Compound meaning multiple. So we're going to see several smaller masses that often resemble our rudimentary or our supernumerary teeth, especially mesodens. This one often does resemble mesodens. The only thing is that these are usually smaller than a mesoden. Our next anomaly in shape is our dens and dentae, and that means tooth within a tooth. And what happens is, as the tooth is developing, for one reason or another, the outer surface of the crown starts to turn in. They call it invagination. So it starts to turn in, and then the crown then develops inside of the tooth. Okay? And it's quite interesting. We actually just saw a patient with this last semester, and it really, it looks just like this. It is a dens and dente, a tooth within a tooth. You can see how that calcified tissue just kind of turns in here. You can see calcified tissues are going to appear. I'm just doing dotted lines because I can control them better. But it appears more white or opaque is what you'll learn in radiology. Okay. This is mostly affects the maxillary lateral incisors. You're going to find those are the culprits of a lot of anomalies. So always be looking for that. It appears as a really deep pit in the tooth, and you think, oh, I need to seal that. But remember, now that tooth, that's leading to pulp, possibly. So you want to be really careful and gentle with that. The patient that we had in the clinic, actually nobody had ever told her about it. It did not have a root canal. It looked just fine, but when I looked at it, I'm like, wow, that's a deep pit. And so then I looked at her radiographs, and what do you know, there it was. So it was kind of fun to see the anomaly. I've only seen it a few times. It's probably one that you'll see throughout your career, but it's kind of an interesting one, I think. All right, let's move on to our next slide. All right, our next anomaly in shape is a dilacerated tooth or dilacerated root. Okay, this is a tooth that has a really sharp bend or curve in the crown or the root. It does appear as though the tooth suddenly bent under pressure. So the term dilaceration is only used if it's a really, oh, why did my pen go right there? If it's a really sharp bend. You can see this is greater than 90 degrees, right? This is probably about a 100-degree bend. And you'll see this especially with third molars a lot. So when do you think this would become problematic? When it needs to be extracted, or if the tooth needs a root canal, right? So otherwise, the tooth is nice and firmly planted in the dentition, but it can become problematic if there's any trauma to the tooth and it abscesses. All right, our next anomaly in shape are dwarfed roots, and this is when the roots of teeth are extremely short compared to their crowns. So remember, we talked about that crown-tooth ratio, and what we learned when we were talking about that is how important that it is that the root is longer than the crown, right? So that it anchors into the alveolar bone nice and strong. So what's happening here is these teeth aren't going to be as anchored. So if this person were to get periodontal disease and lose any bone, it's really going to compromise, and the teeth, they're going to lose their teeth a lot faster if they lose bone. So what I see here, right here, see this little little nodule kind of right there, and a little tiny piece hanging out here? This is calculus. So this patient's in a world of hurt. They've actually lost some bone. The bone should be up here. So now they only have about 50% of their root is in bone. So this tooth is probably going to be a little bit mobile. And I can see, remember I talked about the PDL being widened. So this is where the PDL kind of comes along the tooth, and it's nice and tight. You don't see a dark area here as much. See how this darkness is a little thicker here? All right, that's from trauma. So that tells me that tooth is probably mobile because it's been hit on a little too hard. So it might be raised in the occlusion, or maybe it's mobile, so the ligaments are under too much stress, so they're going to be a little bit wider, a little more stretched almost. All right, our next one is gemination. And gemination is a developmental anomaly. It does arise when a tooth attempts to divide itself or partially twist itself by splitting its tooth germ. So it usually has a single root but a common pulp canal. Okay, so in this picture here, you can see that this deciduous tooth, we know it's deciduous because here's the premolar. So this deciduous tooth has one pulp chamber, one root, but you can see it has two crowns here. See that split in the crowns? So I always think of it as a ring because of the gemination, a ring with two diamonds on it. So one ring, two diamonds. Okay? What we all want, right? So bifid tooth or bifurcated crown. The tooth splits into two crowns with one root. So that's our word bifurcated again. Remember we talked about that with the root canals on worksheet 2, I believe it was. This word right here. It means splitting into two. If it was trifurcated, it would be 3, split into 3. So that's going to come into play when we start talking about bifurcated roots and trifurcated roots. Now, twinning is when one tooth germ splits, forming two nearly identical teeth, but they're fused as one. Okay, so the teeth are developed, but they're basically just fused together the whole way down. All right, so a little bit different than gemination, where it's one root and a common pulp canal, but two crowns. Okay, then we have twinning, which is where it has its own pulp chambers, its own pulp canals, but the roots are basically they're together with at the cementum and the enamel. Okay. All right, our next anomaly in shape is fusion, and this is when two adjacent tooth germs unite. So this isn't like twinning. Twinning was one tooth germ, okay, that created nearly two identical teeth. Where this is two tooth germs that now are joining together. They're fused together. Okay? And these are fused at the dentin. Anomalies in shape, concrescence. Concrescence is when there is fusion between the roots only at the cementum. It's different from actual fusion, which is at the dentin. Okay? And this can happen either before or after the teeth erupt, but it can only occur after the roots have formed. Okay, so as they're forming, this is going to happen. And it's thought to sometimes occur due to trauma in the area. So concrescence, the biggest thing to know about this is that it does happen at the cementum, not the dentin. So I always think concrescence starts with a C, cementum. Okay. Anomalies in shape, hypercementosis. Hypercementosis is just excessive amounts of secondary cementum. Now it's usually going to occur near the apex of the tooth, but it can also occur along the entire root length. So I kind of liked this cartoon on the upper right. It said, straight to my cementum, and it's on their hips, right? The tooth's hips. So I like that for hypercementosis because it shows that it can happen anywhere. Usually our cellular cementum is just at the apex, but with hypercementosis, it can happen anywhere. Now, one specific form of hypercementosis is cementoma, and that's associated just with the localized destruction of bone. And you can see that in this picture here, right here. You can see this dark area. So the light area is this here is the cementum, all right, and then this dark area here is the bone destruction. All of that dark area around that tooth is bone destruction. Anomalies in shape, enamel pearls. So enamel pearls are small masses of excess enamel, and what happens is just some ameloblasts during the formation of the tooth. You're going to find out that ameloblasts create enamel, and it's just a displaced area of ameloblasts, and it's often found at the furcation, in the furcation areas. You can see a furcation is between the roots, so here's where the roots should split, and then here's the enamel pearl. So, all right, anomalies in shape, Hutchinson's incisors. These are notched incisors, and you can see that on this black and white photo on the top here. It looks almost like a flathead screwdriver, the shape of it. So it's often called a screwdriver shape. And this is a result of prenatal syphilis. Another anomaly that's caused by congenital syphilis is mulberry molars, and that's in our second slide here, this one here. And you can see where it looks almost like a mulberry. There's multiple little bulbs here that make it look like a mulberry. All right, so, and then this last picture, you can see they have Hutchinson's incisors here and then mulberry molars down here. Okay, so there it is. Again, caused by congenital syphilis. Anomalies in shape, enamel dysplasia. There are two different types of enamel dysplasia, and there's enamel hypoplasia. Hypo, what does hypo mean? Do you guys remember? Not enough, so not enough enamel. This is caused by conditions that inhibit enamel formation, such as inflammation, fever, systemic disease, hereditary. And so some hereditary conditions, I know people with tuberous sclerosis often get this pitting in their enamel. And it doesn't always appear this color either. That's with time and stain and everything, okay? Very difficult to clean. So this will leave small pits or grooves in the crown of the tooth, so that's enamel hypoplasia. All right. Then we have enamel hypocalcification, meaning it didn't calcify. Okay, so that is a condition that inhibits the calcification. It just, the enamel never gets hard. Okay, remember, we need that calcification to help prevent caries and everything, right? So that could be a really big issue for a patient if it's throughout their mouth. Anomalies in shape, enamel fluorosis. The interesting thing about enamel fluorosis is usually we give the patient enamel to build up their enamel, or give them fluoride to build up their enamel and make it nice and strong. But this is actually a cause of hypocalcification. Okay, so it's undercalcified. It's caused by excessive amounts of fluoride in the tooth. What happened was they found this in Colorado. All of a sudden I can't think of the name of the city there, and they noticed that so many people were coming in with these white spots, all right, on their teeth, and they realized that there was a lot of fluoride in the water. Now, of these people, the ones that didn't have quite as much, or maybe didn't drink as much water, their teeth were actually stronger, more resistant. but there's, too much of a good thing is bad. That's this. Okay, too much fluoride is bad. So you might see this in children who maybe get a hold of their parents' toothpaste and they like the flavor, so they eat it, or prescription toothpaste that has 5,000 parts per million instead of 250 to 500. Enamel caused by excessive amounts of fluoride in the tooth structure. So it has to be, the exposure has to be when the tooth is being developed. Okay, so this is before it erupts. Enamel discoloration, that can include small white flecks. So you see some of that is white flecks, right? Large opaque areas, definitely see that. Opaque meaning white. And then brownish spots, often with pits. Discolored areas, we call that mottled enamel. Okay, so mottled enamel is associated with enamel fluorosis. Now, sometimes students have a hard time deciding, is this fluorosis? Is this, just poor care where they're getting white spot lesions? Well, look at this pattern, right? There's a pattern to fluorosis because it doesn't just happen to one tooth, okay? Because it's happening when the teeth are being developed. So I did my research on the Somali population, and I saw a lot of fluorosis. There's a lot of fluoride in the water in Somalia. And when I was looking in their mouths, I could almost tell when they moved here. When I was looking at the adults' mouths, when they left Somalia. I shouldn't say when they moved here, but when they left Somalia, because the fluorosis would happen until they left, and then the rest of the tooth would be fine. So I could see, hey, it looks like you left Somalia between, 8 and 9 years old, and we're going to be talking about the stages of tooth development and when they happen. And so I could see when they left. It was always interesting. They were always impressed. So that's what you guys should be able to do at the end of this class. All right, amelogenesis imperfecta. Remember, we just talked about the ameloblasts that get displaced for the enamel pearl. Ameloblasts are, or amelocytes, are the enamel forming cells. So when you see amelogenesis imperfecta, that means that there was something wrong with the cells that were creating the enamel. So it's a developmental anomaly related to hypocalcification because the enamel isn't forming. It is hereditary, not acquired. Typically affects enamel of deciduous and permanent teeth. Enamel may be missing, thin, yellow or brown, and easily fractured. So this patient needs a lot of restorative work to make their teeth strong and resistant to caries. It's a very sad condition. Fortunately, I've never seen it, so I think it's pretty rare. But it is hereditary, so if you have one person with it and they stay in your practice and they have children, you might see it again. Here's our Turner's tooth, and this again is hypocalcification, meaning undercalcification of a single tooth. Usually it's a maxillary incisor. It's caused by bacteria or trauma that disturbs the ameloblastic layer, and it leads then to hypoplasia of enamel. So now we have dentinogenesis imperfecta. So what do you think that is? We had amelo, which was enamel. Now we have dentinogenesis imperfecta. And this is going to be hereditary. It's when dentinal development, it's a dentinal developmental abnormality. It's when the dentin is going to be gray, brown, or yellow. The tooth usually has an unusual translucent hue, and the pulp chambers and root canals are completely filled in with dentin. So there's no vitality to these teeth, which makes them then subject to being a little more brittle. Then we have tetracycline staining, and I wouldn't say this is one of shape, but it is caused by the antibiotic tetracycline, which was off the market for about 20-30 years, and now it's just recently come back on. Usually happens when an expectant mother or a young child takes an antibiotic. Expectant mother because they're developing their primary teeth during that time, and a young child is then developing their permanent teeth. So expectant mother, you can see it in the primary teeth, and then a young child, you're going to see it in their permanent teeth. So primary, permanent. All right, teeth of developing fetus or young child, and this can be yellow, brown, or grayish blue. Okay, so you can kind of see the different colors in this tooth versus this one, and I'm not sure if it's the angle of the radiograph, but usually I see kind of the brownish or the grayish blue hue to the teeth. All right, shapes in crown. Most common teeth to show a variety of abnormalities. Number 1 is going to be the third molars. Number 2, or the maxillary third molars. Number 2 is going to be the mandibular third molars. They show in a variety of sizes and numbers, because we can have a lot of distodens and mesodens, and they can be, you could have partial anodontia and not develop them. And also different shapes of cusps. The most common ancillary tooth to show malformation is our maxillary lateral incisor, and you absolutely need to know that. Your boards is more than likely going to ask you something to that effect. So other than the third molars, what tooth is most likely to be pegged? Pegged laterals is very common. So it's just where the laterals look like little pegs in there. I don't see this anomaly very often that they have the picture of, but you know, the laterals, you would just see a little peg rather than a full-on tooth. So abnormal root formation, maxillary second premolars usually have one root, but two may be present. Maxillary first premolars, and this is one that you have to know going into clinic and all that, is that the maxillary first premolars often have two roots, but they may only have one. Okay, mandibular second premolars or canines may have accessory roots, and in all of the above, if two roots are present, one will be buccal and one will be lingual. Okay, so it's not mesial and distal, it's buccal and lingual. So of the mandibulars, you're going to see the bifurcated roots more commonly on the canines. Okay, and then in the maxillary, you're going to see two roots on the first premolars, and those are kind of the key ones to know. Okay, let me just star this one also. All right, dilaceration of root formation is a severe bend. We talked about that earlier, or distortion of tooth, root, and crown of more than 40 degrees, most often seen in mandibular third molars. And then we have flexion, which is the sharp curve or twist of a tooth root only. Okay, so there you have all of the different ones, most of them what we've talked about. And so that's kind of a nice picture to maybe pause and go over what you know about each one of those. Okay? All right, if you have any questions, please let me know. Thank you.